in heart failure, because hydrochlorothiazide is used in heart failure, and so are the ACEs. However, hydrochlorothiazide is not going to be your first line for heart failure. So when we talk about the different drug classes, remember, based on the comorbidities, we're going to have some better efficacy in some drugs are going to help in hypertension, for example, or be harmful in heart failure. Well, ACEs are helpful in heart failure, and so are the diuretics of the class, specifically hydrochlorothiazides. But another drug class I'm going to talk about in diuretics either this afternoon or finish up tomorrow is going to be loop diuretics. They're stronger, they work faster, they're your first line with heart failure. However, hydrochlorothiazide is sometimes added in, but we talked about what drives it being in hypertension, it being hydrochlorothiazides and thiazide-like, is the fact that it reduces morbidity and mortality. Not the case in heart failure versus hypertension. Those are some of the small caveats. Hydrochlorothiazide and thiazide-like in heart failure, excellent for reducing symptoms, right? It's going to help with the fluid overload. But usually it's brought on board after you already have a loop on board and an ACE on board. So yes, the answer to the question is yes, the STAR applies. However, you'll see when we get into those specific comorbidities, hypertension with heart failure, or when we start talking about angina, or when we start talking about other things, there's going to be maybe some nuanced differences. Drugs may still be used from the same class, but they might not be the first line of the backbone that they were in hypertension. Does that make sense to everyone? But it was a good question. Yes, same with ARBs that we're going to talk about now, right? The ones that are noted as useful in in heart failure and hypertension. Same applies when we start talking about the combo. However, just remember that the diuretics that are first line are thiazide and thiazide-like for hypertension, and then we're going to talk about what's first line for heart failure with the loops. So don't get too far ahead of yourself and make these giant, okay, this always works in this, and so it should work here as well. Not the case. That's why they're broken down into hypertension versus heart failure versus angina. So just to make that one clear. All right, we left off yesterday with still being in our first line and our backbone, right? We were still talking about first line backbone for hypertension. And we got through the diuretics, thiazide-like. We got through the ACEs, so we moved into pick one of these if you have stage 1, to pick 2 of these. And if you remember the little flow charts, when we picked 2 of these, we had some choices. We added ACEs in, and now we're moving into ARBs. So angiotensin receptor blockers, the ARBs. They target that same cascade that we were talking about with ACEs. Remember where ACEs hit, right? Everybody remember what I'm talking about? Where ACE intervenes in that conversion, angiotensin 1 to angiotensin 2, and angiotensin 2 being the bioactive chemical that actually is going to impart all those changes that we see in the ROS system. Well, we're just moving one down the line now, right? We're just moving from that conversion of 1 to 2 to actually going on the receptor for 2. So it's a different point. And really, you're going to use ARBs because it's that ACE or ARB / when we talk about peak 2. We're going to use ARBs normally when the patient isn't responding to an ACE or there's compelling indication not to use an ACE, right? What did we talk about? One of the two. Angioedema, we said, yeah, that's an absolute contraindication. Consider an ARB, but also that cough is going to be the most common reason why you switch. Those patients that have that bradykinin-induced cough, we're going to move to the ARBs. Why? Well, if you think about, like we spoke about yesterday, if you know the mechanism, well, if I'm moving down that chain, right, remember that the reason the bradykinin builds up is because ACE helps break it down. So if we move further down the chain, well, you're not breaking down the bradykinin, I'm sorry, you're not cleaving off the bradykinin, so there's not a buildup anymore, right? You're not gonna have the buildup of the bradykinin that you do with ACE because of where the ARBs are functioning. Once again, we do have our suffix, sartans, right? Pick them out of a lineup, don't memorize every drug. Recognize the suffix. We said that on the ones that apply, right? Several indicated for heart failure, which I just kicked that horse for a while at the very beginning of the lecture. So we talked about that they're indicated. So they're a valuable alternative to the ACEs in heart failure too, if you have that bradykinin-induced cough. Often paired with thiazides, as mentioned on the slide. We talked about the adherence being an issue, getting our patients to actually basically have buy-in to what we're doing. It's easier when you have a combination pill. Our advantage on the slides there, minimal to no cough, much lower risk of angioedema. Disadvantage, they cost more. They're still going to be in normally your formulary everywhere, only because if you have the cough, we're going to switch to an ARB. The other disadvantage is they haven't been studied as well as ACEs. When we start talking about those morbidity and mortality changes, haven't been studied as often. What do we do if we have an ACE inhibitor causing the cough? Switch them to an ARB. What do we do if we have an ACE inhibitor causing angioedema? Probably not. We'll start looking at other classes. We certainly don't say, oh, let's switch into a different ACE. Exam pearl for you. Cough on an ACE, try an ARB. So we talked about where they act. They block angiotensin II down at the receptor. So you're still going to have everything downstream of the angiotensin II being blockaded. And we remember that from the little chart where we showed the nephron where it acts, and then it's got the kidney and the adrenal cortex, and it's got showing that changes in sodium and potassium absorption, and also the changes on the dilation of the peripheral vessels. So everything down chain, which is mentioned right on your slide there in the bottom right, is going to be blocked, just like with the ACEs, just further down. So reserve ARBs for patients that don't tolerate the ACEs. Same benefits and renal outcomes as well as cardiovascular outcomes as the ACE. Does not significantly affect the bradykinin levels. Not first choice, excellent first choice if you can't tolerate an ACE. Now on the slide, one of the words you might not recognize, everybody know what apoptosis is from the A2 side? Y'all had that already, remember back? Okay. Programmed cell death, right? Same adverse effects that we saw. Go ahead.
I apologize. So considering they do effectively the same thing, but it seems like the ARBs are a little bit safer. And is it not first line just because like an escalation of force type thing, where like they were going to throw an ACE?
No, because you hit it right. You said seems like. So not as much studying on them. So a lot of everything is driven by that outcome data that we talked about yesterday. Why we use hydrochlorothiazide so much, so often, because the data is there for morbidity and mortality decreases. Same thing with the ACEs. It's just been studied more. At some point, yes, it may take over. They say, oh, use it first line. If you stay in medicine long enough, what was old will be new again, and what was new will be old again, and it'll kind of change around. But the latest data is that ACE is your first line unless you have the angioedema or you have the cough. But as more studying goes on, it could change. Does that answer your question? Right. What do we say about ACEs? It applies here. Pretty much all the adverse effects, except for the cough, are going to apply here. It's a no-go in pregnancy, same as ACEs. Hyperkalemia, still there. We talked about why. Increased serum creatinine, so kidneys, right? Absolute contraindication is pregnancy. ARBs can cause angioedema. There's never a never sometimes in questions, right? It's not an absolute that ARBs won't, they can, but it's just way more common than the ACEs as far as causing angioedema. But still the risk of hyperkalemia, any of these medications that are lowering blood pressure, it can go too much of a good thing, right? You can get hypertension. We talked about that. Renal dysfunction. Exam pro for you. If you see an ACE and an ARB, because you should be able to pick out the suffixes, patients on an ACE and an ARB, and there's something going on that's not quite right, that's the problem. They're on an ACE and an ARB. Don't combine them. Because everything that can happen from one, when you put two on board, well, you just double the likelihood of that happening. So if you see an ACE and an ARB, a patient on both, it's not right. That's a problem. You're never going to have an ACE and an ARB together. Well, not supposed to. You may, but it's wrong. That's not good for the patient. Too high of a risk. The mortality and morbidity downside does not outweigh the good side of trying to get them on board. Because, yeah, in theory, they work at different levels in this cascade of the RAS system. So if one's good, then two must be better. Not the case with these two medications. Okay, moving on to the next one. Your next drug, we're still where? First line. Caveat. There's two different classes of calcium channel blockers. Two different classes. There's the DHP and the non-DHP. The dihydropyridines and the non-dihydropyridines. What is the difference? The difference is when you get that organic compound, dihydropyridine, that's as deep as I'm going to go with you. It's an organic compound. If you didn't learn it in micro or way back when, I never learned it. But if you get that compound on dihydropyridine, then you're going to basically affect more of the peripheral vasculature. If you don't have it, the non-DHPs is going to be more directly related to the heart and heart rhythm, usually. That's when you're going to see them. So we're now in our fourth major class for antihypertensives, first line antihypertensives. And CCBs, calcium channel blockers, they're very effective for blood pressure control. Go right ahead.
Sorry, sir. I have a question.
Sure.
If you have them on ACE and then you want to start them on ARB, that way you can get rid of the break behind off. Is there like a washout period?
There's not a washout period.
So you can just immediately start them.
Yeah, you can. It switched pretty quickly, yeah. Unlike other drugs, if there is a washout for things, and there are, right, in a lot of medications, but not with ACE and ARBs, and I'll make sure that I bring up if there's a washout when we're transitioning. It's not one that is clinically significant enough to say, oh, it has to happen. Calcium channel blockers, especially important for blood pressure control, but specific populations when we start talking about calcium channel blockers. We'll get into that. Big one on tests, you're going to see calcium channel blockers there. The suffix rule does apply for the DHP CCBs. Everybody see it? Pine, P-I-N-E, right? If it ends in that, it's a DHP calcium channel blocker. Not so much with the non. And there's only a couple. So unfortunately, we're back into just got to memorize those two or three. Two subclasses. DHPs, end in pine. You got your examples there, amlodipine, nifedipine, nicardipine. They're first line. So here's where our big shift is. Calcium channel blockers, DHP calcium channel blockers, still in our first line treatment cascade. Non-DHP, no, not first line. And we discussed what they affect more, direct heart, so, and rhythm. So that's why they're not first line for hypertension, but it makes them really useful when you start talking about antiarrhythmatics. Vascular smooth muscles are where the DHPs are acting, right? They're vasodilating without affecting cardiac that much, or really at all. DHPs, not affecting the heart. Minimal direct cardiac effects. Second group, non-DHPs. Verapamil, dialtism. Those are your big two. No suffix. Going to help you there. They're much more effective on the heart. They slow the heart rate. They decrease contractility. So you're going to see them for rate control. This is going to be people that have arrhythmias. You're going to usually be put on a non-DHP calcium channel blocker. But if we're talking hypertension, are they first line or second line? The non-DHPs, first or second line hypertension? Second line. You'll see that one often. What's the difference of the two? What do? They block, all of them, DHPs and non-DHPs, block L-type calcium channels. What does that do? Calcium has to enter into the smooth muscle for contractions and cardiac musculature for contractions. So when we talk about calcium entering, obviously the DHPs are more effective letting that, blocking that at the peripheral vasculature versus the non-DHPs, which block it more on the cardiac calcium channels. So the DHPs, they're a strong vasodilator. They cause minimal reflex tachycardia. Yes, repetitive. What's that mean? I told you yesterday. If it sounds repetitive, that means it's meant to be. Non-DHPs, native inotropic and chronotropic effects, more cardiac selective, useful in arrhythmias, non-DHPs. On the DHP side, also a caveat there, they can cause reflex tachycardia, but not inotropic effects to the heart. So you get arterial vasodilation, reduced peripheral vascular resistance, which lowers the blood pressure. Because remember our old friend, the equation dP equals CO times GPR, right? So the subclass is going to determine if it's going to be more cardiac or if it's going to act on the peripheral vasculature. CCBs, really useful in patients with these comorbidities, right? These are the ones that you've got to be able to pick out of the lineup. Like, when do we use certain things? Calcium channel blockers, if your patient has asthma or COPD, so lung issues, very beneficial. Diabetes, angina, peripheral vascular disease, or isolated systolic hypertension. When we look back at our flow chart for first line, second line, third line, based on the stage of hypertension, you'll see on that far right side of those little block boxes, you're going to see isolated systolic hypertension. The words explain the situation. See a lot in elderly because they start having stiffening of those arteries. So isolated systolic hypertension is a big one for calcium channel blockers. There is, as we discussed, in the literature, maybe still on some of your tests, it may still be in the PANTS blueprint or the PANRI blueprint about the efficacy of the ACEs and the ARBs in African American population. Remember we talked about it yesterday. Later recent studies have shown it's not a big deal as far as their RAS system not functioning as others do. So under that old theory, they were saying that the calcium channel blockers are more effective in first line for BP control in African Americans. You may still see it out there. You guys are going to have cardiology next semester. whoever teaching cardiology, commander of the boards, could probably tell you, hey, what's acceptable, what's going to be on your test when you get to the pants. Right now, currently, it's still in there. Usually start with calcium channel blocker as the first line for African Americans because of the RAS system that we talked about isn't as affected by the ACE and ARBs. Caution in heart failure with calcium channel blockers. Caution in heart failure. Because calcium channel blockers can worsen your systolic heart failure. Now, we're going to talk about one that's generally recommended, but I'm going to give you some cautions on it. It's the bullet underlined in bold on your slide on the board now. Caution in heart failure. Amlodipine, touted as safe if your patient has hypertension and advanced heart failure. However, recent studies have shown like 30% increase of heart failure with amlodipine versus diuretic. So, just wanted to point out that caveat. We're not going to get down into the weeds on testing that. That's more for your clinical knowledge, right? That you'll hear use amlodipine for heart failure. It's good, it's safe, but caution. There's a caveat there. You do block the CYP3A4 channels with calcium channel blockers. Reaching back to that one, everybody's had all that, right? We talked about CYP3A4. Grapefruit juice is going to interfere with it. What does it mean? It means that drugs that are broken down by CYP3A4 are going to be inhibited by this as well. Remember, we got clithromycin is a big one. Some of your antifungals, the azoles, are a big one. Some antivirals. So just know that calcium channel blockers also inhibit CYP3A4.
So to make sure I'm understanding you correctly, amlodipine,
Amlodipine?
yes, it's safe for heart failure, but the risk is that it increases the risk of heart failure?
So it's touted as safe, generally safe. However, some recent studies have shown that it worsens heart failure as compared to a diuretic. So it's always taught as safe, but some recent studies have shown it may worsen systolic heart failure. Is that clear to everybody? I mean, the line is it's safe, amlodipine safe, but caveat as you move through your clinical training, that's kind of the guidelines of what we're doing, kind of catch up with academia. I don't know that it's going to be always touted as safe. So it's more of a good that you know that. Yes.
So test wise, sir.
What test question am I going to ask you?
Test wise.
Not that. Yeah. The ones with stars, I will say, are safe in heart failure. Is that fair? Everybody heard me? I'm not going to try to write anything tricky like that. Like if it's a caveat that I'm just giving you information, I'm not going to go, oh, gotcha. No, I'm not going to do that. No way. Just trying to give you clinical pointers because you're now in a phase of training where it's not just rote memory and regurgitated on a piece of paper and test. You're going to be putting this into practice more and more in the remainder of this semester and next semester, and then certainly in phase 2. Because at the end of the day, we all have to just do what's best for our patients. So I mentioned the CYP3A4 enzyme gets blocked. So any medications that get broken down by it, CYP3A4 enzyme, are going to be affected. And if you'll reach back, I'm pretty sure you had this last semester. I didn't look at all of Pharm 1, but it's grapefruit juice is going to block it. Clarithromycin is the antibiotic that usually comes up. Antifungals. What does that mean? Is those things that are broken down by CYP3A4? Well, they're not broken down anymore, so you need toxicity from those medications. They're hanging around longer. And if you remember, I know this is in there, if you remember your antifungals, that they have some pretty bad side effects on what organ? This is just trivia. The liver, right? So if you're putting a dangerous medication, which we already have to test liver enzymes for antifungals to monitor if there's liver damage, and now we're putting another medicine on board that can keep those levels up could cause more damage. It's kind of good to know. Right? All right, moving on. Adverse effects. There's some kind of unique adverse effects with the calcium channel blockers. Peripheral edema. You're going to hear ankle edema. That's your test cue. They're usually going to say someone with hypertension started on this medication, they have some ankle edema. Very common with the DHPs is ankle edema. Classic exam cue. Flushing, headache, dizziness, fatigue. So do you need to memorize that? No. What do DHPs, CCBs do? Well, they dilate. They dilate peripheral vasculature. So do you need to memorize that? No. All those things, think about what happens when you dilate your vessels in the vasculature. Right? Headaches, dizziness, fatigue, flushing. Verapamil, you're going to see constipation come up always because it's kind of unique. That's the side effect of that calcium channel blocker. We talked about the ankle edema. Be careful with very short-acting calcium channel blockers. Nifedipine is the one that you're usually going to be asked about. It's an immediate release, fast-acting. It can be dangerous because that's super quick vasodilation. So what can happen with that? Reflex tachycardia. You can actually even get an MI in some patients. So it's just a caution for that medication. Instant release. Or immediate release, not instant, but damn near nifedipine. You're usually going to see it tested like, would you give this medication for chronic hypertension? Well, it's an immediate release medication. We talked about it yesterday, so if you think through logically, are we really doing anything for chronic hypertension where we expect an instantaneous change? No, what did I say? Weeks or a month, right? The earliest we were rechecking somebody within 2 weeks for the ACEs, but the diuretics was more like 4 weeks of rechecking those labs. So unless we're talking hypertensive emergency or hypertensive urgency, even with that, you're not going to drop the blood pressure straight out. So if you think through it logically, you should know anything that's immediate release, you're not treating chronic hypertension with it. You're treating an acute hypertensive crisis of some sort. CY3A4, we discussed, it's going to interact with inhibitors or inducers of that, which you've already had, just jogging that memory bank of what it was. I'm not going to ask you, if I ask you anything, it's going to be about the enzyme, not what other things, because that's double jeopardy. You're sitting here, so you've been asked that thing and got through it. Doesn't mean that you won't need to know it down the road. It just means I'm not going to hit it, and Major Art's not going to hit it in this next exam, other than the enzyme and that calcium channel blockers can interact with it. We good on that? Okay. With any of these medications, we're now talking about combination, dual, triple therapy. Well, hypotension is going to be a contraindication on all of them, right? If one is going to decrease the blood pressure, two is going to decrease it better, well, maybe that third one's going to drop it out so low that we're now hypotensive. So that one's kind of intuitive, that too much of a good thing can be a bad thing. I guess you can apply that to pretty much anything, right? All right, now we're going to talk about the non-DHPs, when and when not to use them. On your slide deck, on your student version, make this correction. Make it look like the slide right there. Because when we made the slide deck, unfortunately, we didn't put non-DHP calcium channel blockers and adrenergic system blockers. So one could think when we go to my next slide, without having that non-DHPs there, that non-DHPs are an adrenergic system blocker. Well, they touch it, but that's not their class, right? So I didn't want to confuse anybody because you're reading through the slide deck, you get to adrenergic system blockers, you flip the page and there's non-DHP CCBs and you make the jump to, well, that's a non-adrenergic, it's an adrenergic system blocker. We all know it does affect the RAS system. However, it is a non-DHP calcium channel blocker. Just kind of a study help there. Everybody good on that? That non-DHP calcium channel blockers are not an angiogenic system blocker by class. All right, we're going to go back into dialtism and verapamil. That little chart at the bottom is really good to keep them separated, and then how they're different from the DHPs. But we've already talked about it, right? When we start talking about heart rate, exact opposite of calcium channel blockers from your DHPs. AV node conduction. Remember we talked about the non-DHPs are better for rate control. So nothing from the DHPs are maybe mildly elevated. Same with heart rate, but look at our calcium channel blockers. The dialtism mildly decreases heart rate, AV node conduction, and myocardial contractility, and moderately increases AV dilation and arterial dilation. Whereas your verapamil, it's going to a little more on the heart rate, decrease it, a little more on the AV node conduction, a little more decrease in myocardial contractility, and the same for the arterial vasodilation. So, overarching, what are we saying? That dialtism has a less negative ionotropic effect than verapamil. And if you're visual, that's what's shown by the arrows. What are we going to use it for? It significantly affects the heart and the vessels, and it's going to be supraventricular tachyarrhythmias, atrial fibrillation. Not a first-line hypertensive drug, which we just said on the FACER slide before it. It's excellent when rate control is needed. Verapamil is less selective for the heart than the dialtism. Strong effects on heart rate, AV node conduction, contractility. Used for the same things, right? Angina, supraventricular arrhythmias. You'll see it also for headache prophylaxis, which I think, actually I'm teaching you headaches, either second or third one. So you will see it used, it being verapamil for a headache prophylaxis, specifically migraine and cluster headaches. It can make heart failure worse because of all those cardiac effects. It makes sense if my heart is not pumping enough blood out, it doesn't have enough of ejection fraction. Just looking at the arrows, would it make sense to put a medication on board that moderately decreases all the things that my heart's already not doing in heart failure? It's not pumping hard enough, fast enough, moving enough blood, and it doesn't have enough contractility because my ejection fraction is low in heart failure. So once again, if you think through the mechanism, why would I add that on top of my already non-functioning, failing heart? And that's only going to make it worse. It's only going to make it not contract more, decreasing the conduction and decreasing the contractility. A little bit or a lot of it with both of the non-DHP calcium channel blockers. Just varies by which one does it more, which, as you can see, verapamil is going to have the stronger effect. We good on that? Worsens heart failure. Side effects, just like the DHPs had some kind of unique side effects. You're going to see constipation, verapamil, we talked about it. Bradycardia, we saw, it's listed there on your table, on the slide before it. Worsens heart failure, hypotension and fatigue. If you're not getting good perfusion, you're not going to have much energy. It can increase digoxin levels. That's always going to be on there. Why? We talked about the CYP3A4. If you combine your non-DHPs that act on contractility of the heart, heart rate, heart rhythm, with a beta blocker, which we're going to get into, I think, next group of second-line blood pressure medications, it's bad because beta blockers affect the heart rate and the contractility directly on the beta-1 receptors on the heart. And if you combine that with a calcium channel blocker, just like we're talking about heart failure being worsened, well, it kind of, you're creating heart failure with a beta blocker and a calcium channel blocker through medication, because you're decreasing the rate, the rhythm, and contractility by two different drugs, moderately. And with beta blockers, specifically, selectively for the heart beta receptors. And with the calcium channel blockers, kind of universally on the heart.
So I'm actually getting a little confused.
Okay.
If this non-DHP is gonna decrease the heart rate for a heart failure person, why are we still giving that patient this medication?
Why are we giving a patient a non-DHP for heart failure? So I was saying that there is a adverse effect if you combine beta blockers with the calcium, the non-DHPs, that it can worsen heart failure. Not that you're giving it for heart failure, that you can worsen it.
Oh,
With me?
yeah, thank you.
Anybody else confused by that? Okay, very good. Non-DHPs is not, so is not worsening, I mean, it is worsening heart failure. We're not giving a patient non-DHPs for heart failure. It's a contraindication for those patients. We're good? I know a lot of the words and a lot of terminology sound the same, so it's easily confusing, but we're still talking hypertension, right? So we're still in hypertension. But we do have some heart failure effects or adverse effects with some of these classes of medications like I spoke about, that what's good for one, it may not be so good in another condition, i.e., we don't really use non-DHPs that much for hypertension anyway. It's rate control. It's those arrhythmias, like I mentioned. But it's bad juju if you're using a heart failure patient. Okay. So yeah, added bradycardia if you use it with a beta blocker. Don't use, you never say never, but unless you're very specific about what you're doing, do not throw on a non-DHP with a beta blocker. That, as a PA, that's probably outside your wheelhouse. You gotta be very specific with what you're doing. That's a cardiology. If they decide to do it, okay, but that's not a risk I would be willing to take unless I'm a specially trained cardiac PA. So never say never, but I'm not giving anyone a non-DHP with a beta blocker. That's a very intentional thing. Okay, so this one is the next thing I want you to kind of add to your notes. I kind of added this last week because it's so kind of prominent in the literature right now, but on your facer at the very end of the lecture, we're going way back to what, 3 hours ago, or 3 hours of lecture ago, where I said drugs discussed in this lecture, and I gave you all the classes. Everybody tracking? If you want to, because that drugs discussed in this lecture, that's intended to be a study guide for you. So when you get down into the meat, you go, where the hell am I at? Okay, that's what this is. But I did not put Alice Karen on it. It's still not first line, but obviously we are discussing in this lecture. We're talking about it right now. So if you want to add it, and add what it is. It's kind of opposite of when we were talking about the ARBs. Remember how in the ARBs we're talking about that's working way down in the Ross chain, way down in that antensynogen. I got it right today. In that antensynogen move to angiotensin 1 into angiotensin 2. So when the ARBs are working down there at the receptor for that angiotensin 2, Alice Karen is going the other way. It's going back up, directly inhibited renin. That's why its classification is direct renin inhibitor. Pretty straightforward there. That's what it does. So what does that prevent? My nemesis word starts with A, ends in gin, antensynogen, being converted to angiotensin 1. Everybody with me there? So if you go back to your RAS chart and you look at that cascade, it's acting up higher, right? It's higher than the ACEs and it's higher than the ARBs kind of if you work your way back from the AT1 receptor, it's at the top of the food chain. It's upstream of the ACEs and ARBs, directly inhibiting renin. Don't combine with ACE or ARBs, especially if the patient has diabetes or kidney disease. That's a do not. Usually we're going to use it if you fail an ACE or an ARB, not throw it on as another line with an ACE and ARB. Everybody got me? Use it with, so what does that mean? The other side of that equation is, well, if what can I use it with? First line. It as a second line, adding to first lines. Calcium channel blockers and diuretics only. If you're taking out ACEs and ARBs, so 2 of your classes are now gone to combine with allosterin. So, but you can use it with calcium channel and diuretics, which is the other 2 of the 4 backbone medications that we've been discussing ad nauseum, right? Diarrhea, headache, dizziness, our old friend hyperkalemia, all are side effects. Kind of the same reason as we talked about with the other medications. Can cause renal dysfunction. So we talked about some medicines being renal protective, right? They help the kidneys. This one can cause renal dysfunction. Avoid any potassium supplements and salt substitutes for that security. It's not uber popular, but it is popular enough out there and it's being used. And some guidelines, this is the problem we have with guidelines, right? Is that it's according to who's writing the guideline. Because if I taught only guidelines, well, am I teaching from American College of Cardiology, American Heart Association, American College of whoever? There's lots of guidelines on lots of things. I think I mentioned yesterday the new 2025 guidelines. If you go and read them in all your spare time, if you go back and look at those, they are endorsed by a whole group of people. Now you don't have the Red Cross and the Heart Association, American College of Cardiology, and everybody going, no, yes, back and forth. They have all endorsed the 2025 guidelines, which is going to be better for us, right? Us as providers, meaning that we got a one-stop shop to go to and say, okay, this is what we're doing. Versus, synthesizing kind of all the outside sources and go, well, this is my approved version of what I'm going to do. Having those guidelines helped. And I don't, just to mention it, I know you're ways away from a PANTS, but the PANTS normally does not test guidelines or new studies. It's going to kind of be, okay, this is accepted universally, it's in textbooks, and so a lot of times you'll see the PANTS is going to test you on stuff that's like, we've done it this way and it's going to stay this way until entities come together and make a guideline and everybody in the world supports it, kind of like the 2025 and I'll caveat saying that's hypertension guidelines for 2025 with that new cardiovascular risk tool that we discussed. It's in your slide deck at the end where you can actually go in there and click and get your risk if you want to. Okay. We clear on allosterin, direct renin inhibitor, and we know where it's acting at, what it does. Angiotensinogen to angiotensin 1, i.e. inhibiting that, because renin is what does that. Okay, alpha blockers. Some of these things that we're going to get into now, you probably had, as we start talking about all these different direct actors in the adrenergic system, hopefully it rings a bell back to last semester, because you had, I think your first lecture was like sympathetic, parasympathetic. Yes? So I'm gonna assume that since you're sitting here, you know that, and so I'm not digging down into the whole cascades and where the enzymes all work, but I'm gonna hit on some medications that are second line hypertension and how they work in that system as far as in the adrenergic system. They're second line, sometimes third line, so we're not gonna hit them to the depth of obviously our backbone medications. Fair? Okay, so alpha-1 blockers, they're gonna prevent vasoconstriction. They don't vasodilate, they prevent vasoconstriction. Minor difference there, but there is a difference. They don't vasodilate, they inhibit the constriction of the vasculature. Relax arterial and venous smooth muscle, which decreases peripheral resistance, which if you remember, anything that takes TPR off on the right-hand side of our blood pressure equation is gonna lower BP. Multiplying things by less numbers than the thing on the other side of the equals gets lesser, right? Rarely uses first line for hypertension. Do not use as monotherapy. At least none of the guidelines recommend alpha blockers as monotherapy. They are useful for BPH, benign prostatic hyperplasia. That's where you're going to see them. And you can use an alpha blocker when we talk about resistance in combination therapy. In combination therapy, i.e. our other first-line drugs. And we'll talk about some specific ones next. You will see an alpha blocker used for PTSD, Prazosin or Minipress. So not for hypertension, right? PTSD is not associated with hypertension. I mean, not directly. You'll also see tamsulosin, which is going to be uroselective. What's that mean for the urinary system? For BPH, not hypertension. Orthostatic hypertension. Orthostatic hypotension is your bad side effect from an alpha blocker. You can get reflex tachycardia, edema, dizziness, nasal congestion, and ejaculatory dysfunction. So there's something called the first dose syncope episode. I think it's on your slide. Let's see here. Yep. After the first dose, you can get severe orthostatic hypotension, and actually go syncopal, pass out. Exams love it for some reason, that it's an alpha blocker. First dose, they syncope. What was it? So I bring it up. I don't know if it happens in second, third, or fourth, but for some reason that's a question I see a lot. Is what causes this first dose of blood? So it's usually an alpha blocker, whether they're put on it for their PTSD or for their BPH. So I would know that one. All the other side effects are there as well. Okay, now we're going to talk about central acting agents, right? Alpha-1 agonists. So we talked about blockers a lot. Agonists, well, if blockers block, agonists kind of help along, right? Methyl-dopa, it's kind of the big gun in this class that we'll discuss. An alpha blocker is rarely going to be used. Really, it's not in our sequence of first-line medication, so as far as our slide deck goes, it's not a first-line medication in any way. They act centrally, which means what? On the brain. Are we functioning down in the ROS system? We're talking about a central acting alpha-1 agonist? No. Maybe it has some downstream effects, but this is the alpha-1 receptor's central, which should cue you in that that's on the brain, really. They reduce your blood pressure by decreasing sympathetic outflow. So yeah, it will affect the ROS system downstream, but really it's happening upstream, is that your sympathetic outflow is decreased. And if you reach back to your parasympathetic, sympathetic lectures, first lecture last semester, which I'm sure everybody's done, I would have to bring on new information, but you should know that cascade. I'm not going to test you on it, but it should at least ring a bell. Specific clinical situations, methyl-dopa. So it's going to stimulate presynaptic alpha receptors in the CNS, decreases synthetic outflow to the heart, the kidneys, and peripheral vasculature. Net effect, what happens? It dilates, right? Peripheral vasodilation, which is how your blood pressure gets reduced by these medications, because we're acting out here on that TPR, on that blood pressure equals CO times TPR. We're decreasing the total peripheral vasculature resistance because we're dilating them, which means they're bigger, which means things get through it easier. Methyldopa, slow acting, it's central acting. It's not, none of these medications, other than we talked about the immediate release, but none of these hypertensive medications are like super fast acting. But methyldopa is even on the slower end of everything else. Adverse effects, remember what those symptoms were? If you're decreasing your synthetic outflow, right? Sedation, dry mouth, constipation, postural hypertension. Long-term use, this medication, methyldopa, has been shown to cause depression and nightmares and impaired concentration. You'll see there that we're going to use it sometimes in hypertensive urgency. That's a term that I'm going to discuss with you here in the next hour. It's no longer in the guidelines. There's hypertensive emergency, which is bad end organ damage. And before that, we used to say you have hypertensive urgency, which is this number, oh, that's bad. So now it's just severely elevated systolic blood pressure or severe hypertension. The caveat being end organ damage is an emergency. Drop it now, drop it quick. The other hypertensive, severely elevated hypertension or hypertensive urgency, that's more managed with our oral meds, making sure the patient's compliant, and outpatient. Organ damage, admit, treat. Severe hypertension, or what used to be called hypertensive urgency, or hypertensive urgency. That one is more, we can treat outpatient. Methyldopa can be used in it. I talked about the mental depression, nightmares can occur. Hypertension during pregnancy. There's like 3 drugs on your facer slide, right? Remember those special, when I say your cascade, your blue slides, first line, backbone, kind of 3 hours ago now, yesterday, 3 hours of lecture. These are our first line, stage 1, stage 2, stage 3, and then over here, pregnancy. So methyldopa is one of those alpha agonists that we're going to use in pregnancy. Because we can't use an ACE, we can't use an ARB. We'll talk about those. Okay, so this brings us to beta blockers and a 10-minute break. So if you guys will be back, what time are we on? 1:54, like 5 after work. And I'm up here if anybody has any questions.
Like information?
Yeah. No, it's like the like I'm ahead. Like I'm not going along with my head. I'm just here like
How are you feeling? You look really pale. You look pale. Yeah, you look pale. I'm fine. I feel great. Not fine. Yeah, you look pale. It's like this stagnant. It's like my dad right now. It's stagnant hair. It's hot. Walk, that'll help. Looks worth it.
All those Jews on the academy not waste.
Sure.
After you get up past the blockers, all you have left is hypertension, and then it goes into now drugs.
My maps were killing. Never been for what?
But it's just like it's actually.
Thank you.
Thank you.
Anybody else? First of all, I didn't know that you would get one.
Yes. I'm gonna put that.
Depending who they decide to hire as a new head coach. I thought they should give him 10 years.
Yeah. Oh, yeah, so SCRA, the Service Under Civil Rights Act. So that is federal law saying that, and it's funny because there's still be some medical companies that will be all like, yeah, we will recognize it. It's a law. So like, if they say no, we won't recognize it, you don't take them to court.
Can I ask them?
No. So you can't.
Just say. What is the
Okay, so here's the issue. It's also federal law to be in the service. So look, like read the actual lease. I can tell you in my lease where it says the box where it says on the lease that it's supposed to say. Even if it doesn't say it, it's still federal law.
You know what I would say? I would tell them there's a chance that I might.
That doesn't matter. Like it's law. Like you don't have to be able to read it. So like Kevin
This
said.
is your first time, right?
Oh, that's right. Yeah, so you don't have to tell me. All you have to do is say you want the mark. But it's one is only 7 days.
It has the that's a cat. You and also with like you have to get
What do I,
a break. So the order has yeah, for her like PCS, the only difference is it has to be outside of the PCS. It was like
Early release termination. You have the right under Texas law to terminate release early in certain situations involving military deployments or transfer, family violence, certain sex offenses, stalking, or death, or transfer.
So yes. All you do is you let them know, like, I'm on orders, I can leave the state, I want to terminate my visa in the state. It's typically like courtesy you give to them before a certain time you can be on short list. And you can't be within a 30-day window. So it's no big days, more courtesy. Hey, I'm on orders, like, I want everybody to be here. So your inspection, you get everything done, like, you get deposit back.
Yeah, so then it's the same deal, because, if you just say, oh, yeah, you don't have to, but I would, because if you're leaving your apartment and you're like, oh, everything's fine, I'm like, well, that's not good, and this and that, but if you're there, like, so you're saying, like, you're going through it, like, okay, tell me what's wrong with this.
So you know the easiest way for like renters to get money is to make up BS and get pocket. They would just make up random BS, just be like, oh no, you did this damage, blah 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 blah.
You're basically walking through it, you're basically wrong, you might be this much, like, you can like find or you can correct it on the spot.
So the good thing about longs is if you always make it a long like arcade, because every time you release it, they tend to increase. So if you go long, you can add like a GM. Unless you just absolutely hate it is hot. It's hot drinks. That's wild. Yeah.
I lost that.
You said it's the same thing.
I want to try ayahuasca. You go to like some jungle.
So the key thing why they write things like that, they want to don't have it, so that you like, so you call them like, hey, I want to MLB 74. Oh no, you can't do that because you have to give us.
I borrow like not gonna have to ship it to
I got 3 rolls, so I got a story. He's got a good story.
Because I need something uploaded, but I don't know if they're going to be helpful.
I mean, it didn't help that like my class is Sunday, so I was asking but I walked in there and I just asked them like, I have to sign gas. It's not a how do I spin it? Like, what's the right way to civilian and all civilians? The guy in the back with his head. He's like agitated already with me. Like telling me like I need to spin a car. I was like, okay, like who do I need to press at level? Like, okay, like at buddy level, make sure like gets to you all fast, like you don't come right to us. I said, okay, and I was like, okay, one last question. Like it's all in journal. Because I got it, like the hemisphere ran it. I was like, can I show you the document? It's like, is this gonna be sufficient? Can I show it to him?
I had a good experience at my apartment at Fort Hood. I didn't stay with them.
This is like
Like
document signed by
a
the
little.
hemisphere.
So where do you sleep?
Get a transfer.
this is not, you meet a battalion commander sign memorandum that says you're authorized to translate. It's like, okay, so like you're saying it, you get it translated. Yeah, but these officials are like, you're supposed to give them the attitude. I can translate it. Or I can.
It doesn't.
It's like, it needs to be signed and translated by an official translator. Nobody, not just anybody can translate.
No, it doesn't. Can you see your name, like in English?
Yeah.
And it has the commander's signature at the bottom?
It has like the.
Tell them to just upload that shit to your thing. When they go through your file and they see it with your name and a signature, it's good.
It was like the captain from the Bundeswehr that was like overseeing it. It was like the sign on everyone. It was like it's like the German. Okay. It was like basically it was like it has to be written by Germans.
But they look opposite.
So what I do, I walk down, bring doors down to the battalion commander's office. She's in there talking to the XO. I just wait outside the office. They both see me. They both come out. And they ask me, like, you know, anything can help you with. I get like they have this memorandum.
All right, let's go ahead and get
Trying to
that
get
started. We're trying to finish up hypertension today. I'm hopefully gonna have time to hit a few little check on learnings here. Only slide, somebody, or lots of somebody's picked up, I have a typo. So what's the problem with what's on the board right now?
Alpha 2.
It's an alpha 2, right? So some of you remember back to your sympathetic, parasympathetic nervous system. It's an alpha 2, not an alpha 1. And I think it says alpha 2 in the body somewhere, but I just, yeah, it says it in the first line, right? And the first bullet under mechanism of action. It stimulates alpha 2 receptors, it's not alpha 1. So good pickup, not that, but just a issue with translation with the slide deck for my notes. It's an alpha 2, and I'll change it. I just don't want to bring it down and have to make changes and get out of the slideshow. Knowing this podium might take you 10 minutes. So just make it on your slides, but I will be uploading the slide deck when we're finished with hypertension, just because I want you guys and gals to have the check on learning that we're going to hit at the end. So I may fire through these a little quicker, so make sure we can hit the check on learnings. And obviously we're talking second, third lines, but beta blockers are a beast. You're not going to get it from me here saying this is a selective beta, this is non-selective, this is beta 1, beta 2, this is combine, this is, sympathetic activity acting. So I'll hit them, but it is going to require a little bit of study for beta blockers because it's a broad class to do a lot of different things. And honestly, they're not first line in hypertension, or we'll be talking about them at this point in the lecture anyway. But you can bet when we start getting into some other comorbid disease processes, beta blockers are going to be our best friends. So, okay, alpha 2 agonist, methyl dopa, pregnancy. Moving on. Beta blockers, misunderstood drug class. One of the most misunderstood. If you say hypertension to most people that haven't been through medical training, a beta blocker. It's not. It's not first line for hypertension. Not uncomplicated hypertension, right? Not for stage 1, not for stage 2. It is not first line beta blockers. It is, however, brought on board with some other medications for specific comorbidities, right? We're talking that theme that we've been talking now for 2 days straight, that what's going to drive how we treat things, or not only what's going on with hypertension, but what the hell else is going on. Because rarely is your patient only going to have, they have stage 1 hypertension. That's the only problem they have. Maybe younger military population, may be the case. An older, very healthy adult may have only, systolic pressure elevated, like we talked about, and how you can use certain medications only for that, isolated systolic hypertension. But mostly, we're going to be looking at a multitude of kind of things going on with our hypertensive patients. So the disease processes that they have along with the hypertension, it helps us decide. So beta selective blockers, they're going to primarily affect the heart. You've got your suffix here for the beta selectives, right? Or almost all the beta blockers, if not all. Yeah, all. You got your olol suffix. You can pick them out of the lineup. And there's a list of them there. So non-selective beta blockers are going to block both your beta 1 and beta 2. Not as many to discuss there for your non-selectives. So the beta 1 selectivity is going to matter most in what patients? If I'm asthma, right? Because you're going to have asthma here a couple of weeks. And so if I'm giving a medication that acts as a beta agonist to help dilate the pulmonary vasculature and help you breathe, and then I'm giving you a beta blocker which is going to block that, well, that's no bueno, right? That's not good. They're competing against each other. So asthma and diabetes really are the non-selective beta blockers that block both beta 1 and 2. So with asthma and diabetes, that's a problem because you want to be cardioselective if you have a pulmonary disease or a pancreatic problem. You only want to be working on what the beta blockers do on the heart for hypertension. You don't want to be blocking those other non-selective blockers, which can be bad if they're getting on board and you're also touching into the pulmonary blockers, not just the cardioselective beta blockers. There's a class of the ISA, intrinsic symptomimetic activity beta blockers. There's a few of them there that kind of we'll discuss what their use and what their kind of benefit is for. And you got the mixed alpha 1 and non-selective beta blockers, which being the third or the fourth class, which is your betalol and your cordisolol. And we'll talk about specifically why you would use those. But once again, this is just overall in this class, how they're broken down in different categories. But the cardioselective beta 1 blockers are the ones that have the most effect on the heart and least effect on asthma and diabetes, right? That's on your slide. Last bullet under beta 1 selective antagonist, which means blocker, right? Right, the ISA we'll talk about, they're partial agonists. They were listed on the slide before this, but you got your acebutolol, pindolol, and penbutatol. They're partial agonists. They mildly stimulate the beta receptors, and then they also block. So they kind of do both. And you saw this a lot in your sympathetic parasympathetics. Can be useful for patients that develop severe bradycardia. That's when they're considered if a cardioselective beta blocker causes way too slow of a heart rate. Don't use it post-MI. They don't have a mortality benefit post-MI. I know we haven't hit MI yet, but you're going to hear when we talk about it during acute coronary syndromes, which I think it is like the last lecture before your, next to last lecture before your test. You're going to say pretty much every patient at post-MI is leaving the hospital on a beta blocker. They're not leaving on this time. Right? And it's a big bullet. Avoid post-myocardial infarction. So when are they going to be brought on board? It's your second bullet. They needed a beta blocker, however, significant bradycardia from the beta 1 selective agents. So beta blockers reduce the blood pressure by doing what? We know this should be a revisit, right? They're beta 1 receptors on the heart, and they're going to block them. Therefore, they're going to decrease your heart rate, decrease contractility, and reducing cardiac output. Once again, we're talking about our equation from first lecture. Blood pressure equals CO times TPR. So what are we talking about? Decreasing contractility and cardiac output. So lowers blood pressure. It also, the beta blockers, the beta selective blockers are going to, once again, suppress renin, like some of our other medications. And so that's going to decrease your angiotensin 2 and aldosterone levels, which we talked about what happens when we decrease that bioactive angiotensin 2 and aldosterone release in our RAS system. So you can kind of work your thought process through, well, if it's going to decrease angiotensin II and aldosterone levels, it's doing a lot of the same things that what does? ACEs and ARBs. So beta blockers influence cardiac output and peripheral resistance. So they're hitting on both sides of our equation. I threw the clinical outcomes in there just so you know. It's going to reduce your systolic blood pressure by 10 to 20 milliliters of hydrogen, and diastolic by 10 to 15, about the same. Is it going to do it instantly? No, none of these medications do, except for the instant release one that we talked about, and we'll hit again. So when are we going to use them? Angina, arrhythmias, heart failure, specific agents in heart failure, post in mind, like I said, most everyone's leaving after they get a heart attack, they're going to get the bag of beta blockers. Hyperthyroidism, we use them, migraine prevention, and the key agents in heart failure for the beta blockers are going to be metoprolol, succinate, carvedilol, and bisoprolol, the ciprolol. There we go. And they're all on your slide. There's a little caveat here about lipophilic agents that they enter your central nervous system easier, and so that may cause more drowsiness and mental confusion because they can get into the central nervous system and affect the brain, right? Low lipid solubility have a better CNS side effect profile, and then they're listed out. Atenolol, metalol, low lipid, not affecting your brain and your CNS as much. High lipid, propanolol, and bisoprolol. And you're probably familiar with some of these drugs, actually, beta blockers, the ones that are more lipophilic. Sometimes off-label we'll give that to folks who have, like, for example, standing up in front of people and talking, right? They have, like, anxiety of public speaking or different things, or if they get amped up in stressful situations, sometimes we do give them an off-label beta blocker just to kind of give them a little bit of that effect. They work better with the highly lipid soluble propanolol and bisoprolol. Okay, precautions are big with this class of the beta blockers as a whole. It can mask your hypoglycemia in diabetics, which we also talked about some other first-line medications that do that, so put them in that bucket. Bronchoconstriction and asthma, not the beta-1 selective as much, but as a class, always go back to the slide title. We're talking overall beta blockers, so beta-1 selective for the heart, not as much for asthmatics, but as a class, it's a kind of, a concern. The bronchoconstriction in asthma, it's a precaution, not a contraindication. But you're going to use the ones that are more beta selective. That's how you use your precaution. Lipid abnormalities, common adverse effects. Well, if what it does is slows the heart rate, then too much of a good thing could be a bad thing. So you can get bradycardia, i.e. slows down too much. And we talked about a medication earlier that just 2 slides ago that if you're having too much bradycardia, you can try this class of beta blockers. So you can go back and review it. You can get fatigue, dizziness. We talked about why. You don't have as much contractility or as strong of a cardiac output because beta blockers are decreasing it. Well, you're not getting as much perfusion. So if you get hypotensive, you're not getting enough blood out, then you can get dizzy. Sexual dysfunction is a big one with beta blockers that patients will come back and report often. So we try different medications if need be, if it's severe. Do not abruptly stop a beta blocker. Earlier we talked about a washout period for things, and it wasn't as important as the question was asked, but beta blockers don't abruptly stop it because your heart can then kick into severe rebound hypertension or chest pain or an MI. Why? Well, you've been blocking those beta-1 blockers on the heart, so it's been contracting less, it's been contracting at a slower rate, it's been chilled, basically, not having to work as hard because you decreased the cardiac output with the beta blocker, and then you take it away, and then it over ramps in high gear, right? Everything clamps down and starts pumping and contracting really hard, so you get rebound hypertension, and oh yeah, that can cause you some chest pain, some smashing. Or, in severe cases, a complete MI, or myocardial infarction. What's it gonna interact with? Well, it's gonna, if one thing is a blocker and one's a helper, those two are gonna compete. So beta agonists, and that's true across all classes, right? If I'm putting one thing in that's trying to block this and another one that's trying to help it, well, they're just competing with each other. Calcium channel blockers, interaction. We already talked about what the calcium channel blockers do through those L-calcium channels, right? The ones that are on the heart, and there's a class that's more selective for the heart. Those are the DHP or the non-DHPs? Non-DHPs, we use them for arrhythmias. Well, if you're using a non-DHP and a beta blocker, then you're going to produce some bradycardia, maybe more than you would hope for. And we talked about there's only really 2 of those non-DHPs that are on your slide. So just a little revisit of the verapamil and the altazan. NSAIDs, so they can impair the hypotensive effects of beta blockers or decrease the efficacy of that drug because of the autoregulation of the renal blood flow. So we talked about NSAIDs and what they do to prostaglandins and what that does on the afferent arteriole yesterday. We were talking about combining it. Remember the renal trifecta? Last slide we ended up with yesterday, how that renal trifecta NSAIDs are on board because of prostaglandins. So think about that process when you think about beta blockers. And then clonidine, you had clonidine in parasympathetic, sympathetic. Everybody's giving me a yes. So increased risk. Clonidine, central agonist on the brain, alpha agonist. So really in hypertension, which we're still talking hypertension, really in hypertension, I see clonidine used when it's last ditch, added on at the end when nothing else is really working. We tried all the other backbones, the comorbidities kind of pushed us another way. The patient's still having hypertension, sometimes we'll use clonidine. Off-label, it's often used for drug and alcohol withdrawals too. You'll see that out in behavioral health land. But you have this in Pharm 1, but beta blockers can have an interaction with clonidine. And there we have, once again, a washout, one period. Like I said, the ones that matter I would mention. This one matters. So you don't want to get that clonidine withdrawal hypertensive crisis if you stop it when the beta blocker can be initiated. So you basically taper it down and then you get the beta blocker on board. All right, so these are your mixed alpha-1 and your non-selective beta blockers. So this is touching everything, right? It's a broad beta blocker, so it's hitting the ones in the heart and the lungs, because it's non-selective on the beta, and then you're also getting some blockage of the alpha-1 receptors. So in hypertension, it's going to decrease the rate and strength of contractions of the heart. But it does have the added benefit of not causing any reflex vasoconstriction. So we use it in CHF, it's going to decrease the afterload, inhibits vasoconstriction. That's just a further clarification of the bullet above it, because it's alpha antagonist. And you're also going to decrease the sympathetic tone with the beta blockade, which we said already is non-selective. So it's not our friend that we use in asthma because it's not as causing much effects in the lungs because they're hitting all the beta blockers. It's hitting all the receptors of beta in the heart and the lungs and everywhere there is one. Adverse effects of the mixed, and we're talking, if you go back to your slide, labetalol and carvedilol, bradycardia, cautions in diabetics and patients with asthma. That's a recurring theme for this class, right? Or this class of drugs, not this class/lecture. This class of drugs, we're seeing a lot with caution with diabetes and asthma. It's kind of a clue to where you could focus in on when you're talking adverse effects for the beta blockers. Oops, a little faster than I wanted to move there. Okay. Make sure you all those points instead of jumping ahead like 3 slides of accidents. And the drug interactions. Physiological antagonism, alpha N1 beta agonist. So if you're going to put in anything, as we mentioned, that's a blocker, and you're going to also give them something that's an agonist, they're going to compete. Alpha 1 and beta antagonists, well, if you get one of the other classes that also hits an alpha 1 as a blocker or the beta as a blocker, and then you put this medication on board, well, you just double the fun, right? You just cause double the blocking of either the alpha or the beta, depending on which class you chose. Additive effect is pretty straightforward if you think through the process. You can have with the non-DHPs, they affect the heart, cumulative negative inotropic effect. Once again, it's the same thing. If you know the mechanism of the calcium channel blockers working in the calcium channels on the heart, and what they do, why we use them for arrhythmias, and then we start putting in a broad-based beta blocker that's going to hit those beta receptors on the heart, well, you just crump the heart because you got 2 medicines doing the same things on it. Specifically the non-DHP, because those are the ones that affect the heart more. Mixed alpha 1 and non-selectives, we got the carvedilol and labetalol. They're both alpha 1 and beta receptor blockers. They prevent that reflex vasoconstriction that we mentioned, and it lowers the heart rate and contractility. Heart failure, heart failure, heart failure. Carvedilol, heart failure. Heart failure, carvedilol. That's what you really need to think about when you're thinking about the mixed alpha 1 and non-selective beta blockers is heart failure. Carvedilol being the cornerstone. And then labetalol is, if you go back to our second and third lines over here on the blue boxes for stage 1, stage 2, it's also there with methodopa for pregnancy. We spent a lot of time talking about what you can't use in pregnancy, but this is one of the 3 I think that I gave you that is okay in pregnancy. Methodopa 1, labetalol 2, and we're going to talk about that. Severe hypertension, IV labetalol. It's one of the few beta blockers that when you start having a bad hypertensive crisis, it's quick acting, we get it on board quickly, it drops the heart rate, it drops the contractility, it helps control that blood pressure really quickly, which emergency means emergency. So you need something that works fast because you've got end-organ damage. This is just a slide for you visual folks that shows you the compensatory responses for the combination therapy with beta blockers and diuretics. And it's numbered. I won't sit here and read the slide to you, but you folks that are better visual learners, this can put some of the words I've been saying into a easily digestible picture, showing you where that action is taking place. It's a good thing to look at when you're studying. Just quickly breeze over it and go, okay, I remember and this does this, and then this is a compensatory response. So really learning the mechanisms is more important than memorizing drugs, except for in the cases where we have no choice but to memorize the drugs. But it's better to learn how you pick up on what drug it is and know the mechanism. At least that's the goal, versus trying to memorize every drug in Pharm 2. Okay, so now we're going to talk about direct arterial vasodilators. Nitrates, like nitroglycerin is one you're going to see, sodium nitroprusside, hydralazine, they are going to all directly relax arteries and the arterioles and the smooth muscle. So what are they doing on our equation? They're decreasing that vascular resistance, that peripheral vascular resistance, which is part of the total peripheral resistance. So make it bigger, make it open, things get through it easier, right? So blood pressure drops on the left side of that equation. See if I can get this on board before we go to our lecture. Okay. Mechanism of action we mentioned. So obviously it's going to reduce your arterial blood pressure by doing that. Clinical use combined with combination of nitrates. You can have isosorbide dinitrate and hydralazine. And they're gonna treat hypertension and heart failure in African American patients when we're saying that, you know, the ACEs and the ARBs aren't as effective fascias. You'll see often that you combine a nitrate, isosorbide dinitrate and hydralazine, and that's vital. I don't know if that one's on your slide. Maybe on the next one as we move on, but if not, it was just a clinical pearl anyway, not something I'm going to test you on. Off-label, we're going to use some of these for preeclampsia or hypertensive emergency. Quick vasodilation, open it up, drop the blood pressure quick in emergency. You can use some of the nitrates or the direct arterial vasodilators as an adjunct agent to prevent reflex tachycardia in pregnancy. Hydralazine is one that you will see to prevent reflex tachycardia in pregnancy. For the direct arterial vasodilators, adverse effects, you can increase the plasma renin, which can cause sodium and water retention because we talked about what renin does in the ROS cascade. You can also get some headaches, tachycardia, nausea, sweating, arrhythmia, angina. Think about what it's doing. It's a direct dilator of the arterioles and the arteries. Usually going to use a beta blocker with any direct arterial vasodilator. And then you're going to use a diuretic to counteract that sodium and water retention because of the renin activation. Okay, this is going to be a quick review. And then we're going to talk about hypertensive urgency and emergency, or what we call now severely elevated hypertension and hypertensive emergency. This is back to the very first of the hypertensions. This is one I've referred to numerous times. What's our goal, right? Below 130. Just know the stages. Stage 1, stage 2. 1's one drug, 2's. And you have a choice of 3 drugs of the 2 you want to choose. And then we got our special classes and our second and third lines. So we talked about, like I said, the blue slide with the different categories with the stages there and the medications and your choices. That's a money slide as you review hypertension. Nothing new there. This is the 2017 guidelines. I talked to you about the cardiovascular 10-year risk calculator, that there's a new method out there, the PREVENT. But this one, like I said, these came out in 2017. It's been updated. It's still in the literature, and you'll see it on that same slide I was just referencing, that when we talk about the cardiovascular risk index score, if it's greater than 10%, then we're going to start treating if the CVD or the 10-year ASCVD event risk is 10% or higher. It's kind of gone out of favor just because the PREVENT takes into account way more things than to predict stroke, MI, those things can be caused by cardiovascular disease. But I wanted to keep this slide in because you can still check out the calculator there on the bottom right and see what it's all about. So the key there is even with your 130 over 80 is recommended if you have confirmed hypertension greater than 130 or 80 or that 10% or higher on the CVD risk score. I'm not going to hit you on the risk score because I'm not testing guidelines. If I do, it's going to be in there with patient as stage 1, stage 2 hypertension. So we'll need no guessing there. Is that fair? I mean, if you see the 10% risk elevated, it's there just as extra. It's not to drive a clinical decision, right? Because we're going to give you stage 1, stage 2. We're not going to have you diagnosed. I'm not going to give you like hemoglobin A1Cs and fasting blood glucoses and kidney creatinine clearance and BUN and say, how do you treat this patient for this blood pressure? And then you've got to go through, okay, shit, they have kidney disease, they have diabetes, what the hell? We won't go there. We'll say patient has chronic kidney disease. And you'll see that here in just a minute when we get to check on learning for the last 10 minutes. There's our old friend. So as you'll see for stage 1, we're saying calculate, by the 2017 guidelines, calculate the risk. And then if it's less than 10%, they're saying lifestyle modifications, diet, exercise, all those things. But we're gonna give you if they need to be treated or not treated and what stage they are. You won't have to classify. So if they're stage one med, either thiazide, ACE or ARB, not and ARB, because that's bad, and then calcium channel blockers.
Sir, quick question.
Yeah.
So for pregnancy, like labetalol, if you have a patient who they were on labetalol and then they get pregnant, is there any consideration to reducing a dose, adding a dose, or do you keep the pregnant woman on that same dose during the pregnancy?
It's a good question, and I think with all things you're gonna base things off for signs and symptoms. What her blood pressure is doing. You're probably gonna get the OBGYN involved too, because if we're moving towards an eclampsia or preeclampsia diagnosis, then that changes things a lot. So probably not gonna mess with it too much in the early stage of pregnancy, but based on how her body responds physiologically, because we know it's gonna go up, right? It's going to go up, being pregnant. But I think that's probably a monitor it and watch it and kind of see where we're going, and then decide if we need to up it or change anything if we start moving into that pre-eclampsia or true eclampsia phase, which that's you're going to get that more in OBGYN. But it's a good point. Like anything, bring her in, check it, see where we're at, get a log, and then decide is this something I need to look at or are we okay? Does that make sense? Kind of cautious, treat the patient, not the numbers kind of thing. All right, individualized treatment. That's what we've talked about, right? And here's some high points. I'm not going to, we've hit these ad nauseum throughout the lecture, but this is a good little overarching, not by drug class, but just like things to think about as far as hypertension goes. And it's funny that, I just responded to your question, but that's the whole goal. Individualize it to a patient. There is no, if this, do this, if this, do this, if this, do this. You kind of have to make your best educated guess, bring them back in, see where we're at. What are we doing? Checking labs, right? We're checking BUN, creatinine. On almost all these, we've got to look at that potassium, kind of an underrated one, the magnesium. We want to see what that mineral is doing, right? We're looking at the sodium. We're looking at the BUN. We're looking at the creatinine. If they're diabetic, or probably even if they're not, we're getting a blood glucose evaluation or hemoglobin A1C. So you're repeating those labs and then putting everything together, getting a full picture of what we're going to do. We're going to change this, tweak this. Rarely is your hypertensive patient just going to come in, you give them the first med that comes to mind out of your top 3, and they go come back in 4 weeks, and they're good, they're golden. It's a balancing act, because as we talked about, for a lot of things that we do, there's going to be a counteraction that may come back to bite us down the road that we then have to kind of maybe consider changing the med, because we're treating individualized to the patient, right? And not all, if every one of us take the exact same drug with the exact same milligrams, a lot of us may respond the exact same, but it's all going to be a little bit different, right? Based on our own unique physiology. Key considerations, we beat them to death, right? And guess what? They're not going away. When we get into diuretics tomorrow, when we get into heart failure, when we get into angina, they're all going to come back and get us in those diabetes, chronic kidney disease, albuminuria, and pregnancy. Stroke history, MI history, keep it in mind, right? There are some caveats on these drugs here, but these are all spelled out earlier in the lecture. This is an overview of how do I treat hypertension? Well, you better think about this. Okay, so this is more of a review slide. Most patients will require more than one. Secondary stroke prevention, avoid calcium channel blockers. It's underlined in bold, so probably important. We talked about this, right? Why is our patient, or why is the treatment of our patient sometimes inadequate? Well, they may not be taking the medication that they got from the pharmacy. They may be like Dennis Reynolds in our video yesterday morning, stop right there. Medicine is for old people. And if I wanted my blood pressure lower, I would just mentally will it down. So they may not be taking your medication. So you have to have, a good relationship with your patients to make sure there's medication adherence. There could be pseudo-resistance. We talked about white coat. Or did you choose the wrong drug for what's going on with this patient? Well, that's when you reanalyze, did I take everything into account? Did I catch that they were already hyperkalemic and then I put them on a medicine that's gonna raise their kalemia? And what are these weird EKG changes? You know, there's a whole picture for each patient. You can have drug-related causes, i.e. did you really look about, like I talked about, a lot of comorbidities flying around, right? So usually we're not treating hypertension isolated in a bubble. Did you think about what other medications are on board for the comorbid diseases, specifically the ones that we mentioned on the last slide, but there's many more. White coat effect we talked about. We talked about how do we improve? Well, a lot of it's just good patient communication, bedside manner, but it's also using those combo pills when you can. If you can get them to take one, but they won't take two, we'll give them one that has two drugs in it if they need combo therapy, if they're stage 2 or stage 3. Using long-acting drugs, longer acting if available. We talked about, hypertension. It's not a short game. There's some easy wins, but it's really not a short game. A lot of times it's following the patient, and they're going to be back in every month, 2 months. Once you get them stable, maybe twice a year, once a year, but it's really monitoring is what comes into effect. Patient trust, empathy, real world medicine, right? I mean, if you're not buying into what you're selling, then nobody's going to buy it, for sure. So you have to let your patients know why it's important, so they don't try to wheel their blood pressure down on with their own powers. Okay, I hit it. Severe hypertension versus hypertensive emergency. Numbers are important. What's more important is end organ damage. Is that blood pressure so high that it's affecting my brain, my kidney, am I confused? What's going on where my blood pressure is so high up that it's affecting my heart, it's affecting my eyes, it's affecting my brain? Got to drop it down. The old term severe hypertension was previously a hypertensive urgency. And for whatever reason, people got kind of, well, urgency, hypertensive emergency. But really, with hypertensive urgency or severe hypertension, your cutoff from that in an emergency is end organ damage by signs and symptoms of end organ damage. And you should kind of be familiar. Just think about if you have super elevated blood pressure, what are you going to see physiologically on your patient's signs and symptoms? Their labs, their EKG, that kind of thing. Their symptoms, crushing headaches, you're looking in and you see busted vessels in their eyes, EKGs way out of whack. Sometimes, if we think numbers only with severely elevated hypertension, I can tell you right now that you can have a patient come in, sit down, they look normal, everything's fine, blood pressure cuffs on, medics doing their vitals, you're doing the vitals, whatever the case may be, and you're like, 200 over 110. Holy shit, call an ambulance. No, they're walking into your office, they're fine. Your body is amazing at compensating for those type things. And they'll just like you don't treat it quickly, in a short amount of time, you reverse it, really your body is not going to get to that level and accept it quickly, right? And for me or you or some of us, that blood pressure may be a hypertensive emergency. We got end organ damage, but for this patient, they had those compensatory responses for years and years and years. So 200 over 120 that's their norm, or they can tolerate it. So when we start talking about severe hypertension or previously hypertensive urgency, if they're not showing end organ damage, it's make sure they're taking the meds you gave them. Maybe you had something else on board, but it's outpatient. Even if to you it's an alarming number, right? So we don't just treat numbers. Now we're looking at hypertensive emergency. You got end organ damage, and yes, you have very high blood pressure, which it may even be lower for this person with end organ damage than this person that just has severe hypertension with no end organ damage. This number in an emergency, because it's causing end organ damage, but this patient's an emergency. Whereas the same number over here could be even higher than this, and it's just severe hypertension or hypertensive urgency, you could treat outpatient because their body's compensated. So the key take home there is end organ damage, and know the numbers. I mean, it's a good place to start. I mean, 180 over 120, yeah, that's high, but I can tell you that I've seen numerous patients with those numbers, and they weren't in, now, usually not in a young military population. That's more civilian side or maybe in some of the other facilities for our elderly. We treat it with oral meds. If it's end organ damage, they're staying with you, and they're staying on the intensive care floor. So they're probably not staying with you. You're calling an internist to admit them. And you get IVs on board, fast actors. This is a chart. I won't go into every one of them, but for hypertensive emergency, these are the meds you can use, and there's the adverse effects there. Nitroglycerin, we're going to hit that again, a lot of these again in ACS. So it's all going to be tested on the same test. That's why I'm not digging too deep here, because we're going to talk about these in acute coronary syndromes. But nitroglycerin is preferred for ACS. Do look over this. Anything that's bold, is free game for the test. But I won't go deep diving in all of it. Just know the adverse effects probably, and if there's a note, that's probably important. Pretty straightforward. I hit hydralazine a little bit. I talked to you about its use with preeclampsia and eclampsia, which if you haven't got it yet, you will get. You're pregnant female where blood pressure, protein, everything's rising up, right? Hypertension emergency for the hydralazine is more of an off-label, but it is used. So I won't deep dive into that because I want to hit these questions the last 2 minutes. Esmolol and labetalol. So what are they? Because they end in olol. Labetalol. You're going to see them every exam you take. If it's a certification exam, whether it's your first one as a PANCE, recertification as a PANRE longitudinal, these two drugs will show up for hypertensive emergency. Not both, one of them will be there. Know these, look at this chart, right? It's in red, it's IV. I will point out the note on the bottom right. Esmolol and labetalol. Aortic dissection. Classic. Test question, well, it's, very quick onset. You have to do something very quickly. So you're thinking IV, and you want something super fast acting. So you're going to see esmolol or labetalol there as a choice. Hopefully, it's not going to be both of them because they're both used according to what formulary is in your hospital. But one of those two will be mentioned for aortic dissection as an option, and that is the beta blocker in IV preparation that you're going to grab for aortic dissection. And look just over briefly the adverse effects because we already talked beta blockers. So these are just caveats in hypertensive emergencies. And there's a couple of them that say, hey, think about this in pregnancy, eclampsia, preeclampsia, think about this in ACS, and in this case, think about it in aortic dissection. All right, so this is what you're going to see throughout the entire block from me and from Major Hart. We build all the slides together. So I will be, I think the first 2 lectures in block 2, I'll have with you guys as well. And then she'll kind of take over because I'm going to be teaching, well, it'll be you guys, I'm teaching GI as well for you. So that's obviously later in the semester. So it'll be a memory jog. What we're going to do is the end of every block, not the end of every class, as you see hypertension, that's 4 hours. But I can tell you that if you really went hard and you studied hard on these 4 hours, the next 3 to 4 blocks of lecture are going to be super easy because the next one's diuretics. So I shouldn't have to talk much about hydrochlorothiazide and thiazide light, right? I should be talking about what I mentioned at the very beginning, that for heart failure, there's a class called loop diuretics that's more efficacious. So I would say that the meat of everything we're gonna do in this entire block came out of these first 4 hours. Everything else now we're just gonna add to. I'm not saying it's gonna be easy. I'm just saying we have to spend less time because you understand the RAS system at this point. I'm convinced that you know the RAS system. And also the thiazide diuretics, all the stuff we went over today, the ACEs, the ARBs, the first lines. So we're just gonna be giving caveats here in angina, acute coronary syndromes, heart failure, because we hit a lot of heart failure in this lecture. So with that, let's spend the last 10 minutes here getting some check on learnings, unless there's any burning questions. But I will be up here right after we're done here, and then we're lecturing again tomorrow where we're gonna move into diuretics. Not a new topic, just some new classifications of it. So for the memory jog, these are just the high notes, right? This is not, you see my red star? Don't say that Dr. Mercer said if I looked at the memory jog slides that I'm going to pass the test and I'm good to go. I am not saying that. I'm saying to use this as a good anchor for your studying, but there's no way that you can look at this and the next 2 slides and know everything that you could potentially need to know for hypertension. I'm just saying these are some repeat offenders on national exams, which means we should probably test them too while you're in the academic setting to get ready to take that academic exam. This is not all you need to know though. You'll see that disclaimer on every one of them. It's not all inclusive, but it's a good anchor, a backbone is the word we like to use, right? So refer back to them. They're basically just little bullets. If you don't know what those bullets mean, then go back and look in the lecture. Because you should be very familiar with what we're saying here. I'm not going to read those to you and let you do them on your own because I think we get more bangs from our buck getting 3 or 4 good check on learning questions, which that way you'll kind of see how these questions are going to be framed. But I can't give you too many because then I won't have anything to ask you to come test that. So, but I want you to see kind of how they're going to be framed. So once again, those last memory jogs. And oh, by the way that we frame these, we being myself and Major Hart, tomorrow before we get into diuretics, I'm going to hit these hypertension memory jog slides again to do what? Jog your memory, and then we'll move to a new topic. So that'll be a chance for you to ask me at that point. What are you talking about? About hypertension, so that we're all, baseline, starting on diuretics. So look over these tonight, so that tomorrow when I bring them up again, if there's any questions, we can hit it before we get to our next, coming attraction, diuretics as a whole, not just thiazides. Okay, check on learning 1. 70-year-old woman, hypertension, chronic AFib. She presents with a resting heart rate of 110. She has asthma and cannot tolerate beta blockers. Which medication best addresses both her blood pressure and her heart rate? Anybody? Whenever you think you got it, just raise your hand and say it. Nobody wants to be bold?
C.
I hear some C's, I hear some B's. And so you'll see all my check on learnings. Not only am I going to give you the answer, I'm going to tell you why it's the answer, I'm going to tell you why the other answers are wrong. C. Non-DHP, rapid dioxazam, reduces AV node conduction, effective for rate control in AFib while lowering the blood pressure. Amlodipine, which is what? DHP, kind. Lowers but does not control the heart rate. Because remember, the non-DHPs affect the heart rate. That's the benefit of the DHPs, is they don't affect the heart rate. Nifedipine, reflex tachycardia, increased MI risk. These are kind of hard when we just went over nifedipine in a table like 10 minutes ago, but we're trying to synthesize all this together. Hydralazine, reflex tachycardia again, it can worsen AFib, and you'll see that in the chart. Losartan, what is it? Or is that going to affect your heart rate? No. It's cardioprotective. It's not. 2, 60-year-old man, hypertension, chronic kidney disease. Started on lisinopril, which is a ACE. Okay. 2 weeks later, creatinine increased 1.4 to 1.6. Potassium is 5.1. He is asymptomatic. What is most appropriate management? Anybody? I'm sorry, I'm gonna start wearing my hearing aids. Okay, we're hearing some C's. Why? Why? Because it's an acceptable, known change, right? Continue lisinopril and monitor. 20% rise in creatinine after ACE is expected, is acceptable due to afferent arterial dilation. Potassium is mildly elevated, but he's got no symptoms, right? And it's not, definitely not at a dangerous level. And probably on your exams, I did say asymptomatic, but I might even, you guys have had lab though, haven't you? Yes? So everybody knows what, I'm not gonna hit you with, oh, I'm right on the edge of elevated potassium versus not. We're not playing that game. If it's something you need to know, we'll be damn clear. You know, potassium of 8, there'll be something way up there. But I'm not playing games with make a diagnosis and figure out how to treat. As you can see, I'm giving you what it is, right? What the diagnosis is. So we're going to continue it. We're not going to discontinue it because we know that we're going to get that 15 to 20% rise. It's expected. We're not going to switch because you're going to have the same similar renal effects. We don't add potassium because, yeah, the potassium's okay where it is, but it's you don't want to make it worse and now put them over that threshold where the potassium is symptomatic, right? All right, last one. 63-year-old woman started on chlorothalidone for hypertension. 2 weeks later, dizziness, standing, and pain in her right great toe. Lab showed potassium is 3.2, uric acid is 9.1. What's the effect that's best explained by her right great toe pain? Hyperuricemia. We hit it, right? And here's why. Thiazides reduce uric acid excretion, competing for renal secretion. Increasing serum uric acid and precipitating gout attacks in susceptible individuals. You know, hypokalemia doesn't have anything to do with great toe pain or joint pain. Hypernatremia, confusion and seizures, not gout. Hypercalcemia, we talked about what it could cause, kidney stone being one of them, but it's not deposits into joints like gout. And volume depletion can cause orthostasis, but not joint inflammation. So I wanted you to just have an idea of how the questions are going to be framed. I'm going to give you the diagnosis. I'm going to tell you what we're looking for. So you're not diagnosing, but you've got to recall back these classes of meds, indications, contraindications, adverse effects, what they're best used for, what they're not used for, right? Everybody feeling good? Hypertension. Ready to move on with ourselves tomorrow to diuretics, specifically those other than hydrochlorothiazide. All right, but let me get off this podium before Dr. Love makes me stay late, and she's mad because she needs to get her class taught to you, right?